I'm going to whiz through all the various ways that I use to try and improve the visualization of injections. To get the best results, you have to be able to see the right veins to inject, and then you have to inject the right amount of sclerosant, the right concentration with the right pressure and volume. Now, of course, to be able to inject these veins, you need to be able to see them. And I'd like to share my screen at this stage. And there we are. So I'm going to talk about injecting and visualizing small veins. I'm not going to be talking about truncal veins or varicose veins. I'm confining myself to the small veins. Now, we all know that veins in the dermis, that is the telangiectasia, and the veins just underneath the dermis, the reticular veins, are connected to a network of veins through a very complicated pattern. And this sketch of a scheme indicates that these telangiectasia are connected to reticular veins, to truncal veins, through the superficial fascia and through the deep fascia into deep veins. I used to classify telangiectasia as either idiopathic or secondary. But I'm finding that as I have better and better visualization aids, the category of idiopathic is getting smaller and smaller. And it seems to me that spider veins don't appear out of the blue for no reason. There is either a connection to a deeper vein, to a reticular vein, and we now know that, of course, microvalve failure in the skin vessels, the reticular vessels, is a way in which these spider veins develop. So I think my old classification is idiopathic and secondary. Now I ask myself, why has this spider vein cluster developed? And that's where being able to visualize the network of veins is so important. Now, let's talk about the common visualization aids. There are 5 of them: simple magnification, transillumination, cross-polarized lighting, near-infrared vein finders, and high-frequency ultrasound. And here's a sketch. I've used all of these except the cross-polarization headlamp, but I do take cross-polarized photographs, which I'll show you. Currently, I use all of these methods in my practice at various times. So good magnification and illumination, I think, is essential. I don't think you can really inject small spider veins or reticular veins without good magnification. This is my colleague Kathy McGuinness, who's demonstrating a simple mag lamp, which is a floor standing device that allows her to see veins more easily. Transillumination, it's a horseshoe shaped device with a ring of LEDs, bright LEDs. We have red and orange LEDs. The red ones are very good for showing up deoxygenated blood in blood vessels. The orange ones penetrate somewhat deeper, and they allow you to see the vessels deeper and people with darker skin. And it's a very simple device. I like it. You can hunt for clusters of veins near spider veins. You can see them quite easily, and then you can rotate the vein light to allow the needle to come in. So this is the way in which we look for the reticular veins, and then having found them, we would rotate the vein light through 90 degrees and then inject through this gap in the horseshoe shape. And I think it's a very good device. It provides traction, it provides some engorgement of the reticular veins, and it allows you to see the needle, and it allows you to see blanching of reticular veins in association with clusters of spider veins. I think cross-polarized lighting is very good. I do take photographs, particularly before and afters, using cross-polarization. This is without, and this is with, and what you see primarily is it takes away the glare, and some of these very, very fine vessels that are very difficult to see with magnification as well will be easier to inject. And certainly the Cirrus headlight or a cross-polarization system similar will allow you to see and inject small vessels well. It doesn't always show the reticular veins better, but in occasions it does, and it makes them easier to inject. And this is how I perform cross-polarized photography. I have bright LEDs. I'm able to place a polarizing filter in front of the light source, and then with a circular polarizing filter on my DSLR camera, I can take cross-polarized photographs. I also have been persuaded to part with my children's hard-earned inheritance, and I've bought myself a near-infrared vein finder. And I do like these devices. I think they give a very good view of reticular veins coming into telangiectasia. This is a photograph without cross-polarization. And as you can see the reticular feeding veins. And this is real time. So you can apply pressure, you can milk the blood out of these vessels, you can release, and you can see which direction the blood flows. So you can check for valvular incompetence in reticular veins, which I have to say I find very difficult to do with color duplex. It's often quite difficult to inject under near infrared, but what I like to do is I like to mark the veins with the vein finder, and then I like to inject them without the vein finder, if that makes sense. Often, I have to say, with the aid of ultrasound. Do bear in mind, though, if you're going to mark these veins for injection, you probably ought to lie the patient down to mark them rather than mark them in the standing position. And my favorite is the 18 megahertz high frequency ultrasound. I've got an 18 megahertz ultrasound machine and I use it every day. So I've got all of these. This is not me showing off. This is me showing you what I would use in my clinic. I've got a mag lamp, which I don't use very often. I use a vein light, near infrared, high frequency ultrasound. I like to have a high intensity LED light source on my head, and I use surgical loops because I think they give the best optics. Did I keep to time, Hilary?
You did. In fact, you were a minute before your time, Haroon. Well done.
Steve, the gauntlet was thrown down and the bet was accepted. No, it wasn't accepted, actually.
I lost my money, Haroon.
All right. Well,
can we apply the same principle to our future board meetings?
Indeed. Yes, I do waffle on.
Could you end your screen share, please, Haroon?
Of course.
Thank you. Thank you for an excellent presentation.
Very good.
Questions for Haroon. Stephen Blair, I know that we've had discussions in the past about near infrared, so I thought you might have a question for Haroon.
Yes, I mean, I've looked at a number of these devices, and I have to say I've not been as convinced about a number. The VeinLite, actually, if you're holding it with one hand and then using the other hand to cannulate, you then got no further hand to start adjusting syringes and so on, and it becomes a two-person activity. And there are an awful lot of sclerotherapists who are doing the cosmetic end of things, who are doing it on their own, and they also have an issue of how much these things cost. For those sort of nurse sclerotherapists, what would you think would be their best option to improve outcomes?
I think it's diminishing returns, Stephen. You're absolutely right. I think I'm in a fairly high volume practice, and I can afford a near infrared vein. I would have a Transillumination device, and I would probably have a headband magnifier and an LED light. I think those are sufficient. But as I said at the beginning, I think really there are very few so-called idiopathic spider veins. And I think the harder you look, the more you find reasons, particularly if you have a high frequency ultrasound, you'll see little defects in the deep fascia, and you'll see communicating veins to clusters of spider veins where a vein light will show you nothing. There's nothing feeding into it because it's a perforator coming from directly underneath. Infrared viewer won't show you anything either. So I think you need either a vein light and good magnification, and I think really high frequency ultrasound. That's my view. I don't have a Cirrus headlight.
I mean, I think the high frequency ultrasound is clearly the best thing, but also worth pointing out that sometimes people use these devices to see where there is no vein when they're doing fillers and all the rest of it in a cosmetic.
Sure. Yes, sure.
Can be equally useful, really.
Sure. The other comment I would make is that if you're going to persuade your patient to commit to what may seem to be quite a long, drawn-out bit of treatment, a near-infrared imaging device over the cluster of veins, as I showed you in my slide, what appeared to be a small little cluster of veins on the outer part of the leg, and you demonstrate so-called feeder veins. I don't like that term, but it's clearly an incompetent reticular vein in association. They suddenly see that actually all these things are connected. And if you explain to them, they don't occur out of the blue. There's almost always a reason. And if you don't deal with the reason, you get less than satisfactory results, and you're more likely to get matting and more pigmentation if you don't deal with these problems. So it may seem like overkill. It may seem like an aesthetic physician or an aesthetic nurse would find it hard to invest in these things, and I agree.
Okay. Haruna, the audience member has asked, what make is your high-frequency ultrasound?
It's a Chinese machine. I had a SAO tape MyLab 5, which is my favorite. It had a lovely 18 megahertz probe, and it became, as Philip said, it became obsolete and it couldn't be repaired. So I bought 2 Chinese ones with 3 different probes, and I think the whole lot cost me £18,000. So it's a Chison. It's a Chison, Chison.
And Stephen Tristram, any questions?
No particular questions. I first injected a vein in 1966 in the Tyndall General Hospital in Aylesbury as a 4th year medical student, maybe 5th year. I'm delighted I started his progress to such fame in 2009, Zola. So, and I was a reticular vein man then, and I still am, if you remember that. I find ultrasound crucial. I'm going to talk about another little gadget that I've been playing with, sadly, through a difficult period of lockdown, but I have no particular questions. I thought that was all excellent. Thank you.